Leprosy, deformity, and disability. So these terms, they are a sequence from nerve damage to social impact. Impairment means loss of any structure or function. So either nerve can be damaged, so anesthesia can be there leading to ulcers, motor deformity leading to contractures or autonomic function loss. Then any visible alteration is defined as deformity, and disability is inability to perform any activity. It can either be due to anesthesia without visible deformity, or there can be visible alteration. Now these deformities, they can be either primary, which were due to direct infiltration of skin or nerve involvement in the form of motor or sensory function loss, or secondary, where there can be sensation loss leading to formation of ulcer, or if there is no use of the extremity, there can be contractures. Then the WHO disability grading. So initially they were graded in 1960 as the first grade was anesthesia. So anesthesia just requires physiotherapy and prevention of disability. Then mobile claw hand was described as grade 2, which would require reconstruction surgery. Then any contracture, if happens, or resorption of the bones, it would require rehabilitation. So they were graded as 3, 4, and 5. Then in 1970, there was one 3-point scale for hands, feet, and eyes. And in this, grade 1 was loss of sensation. After that, grade 2 and grade 3, that was not described clearly because foot drop is there in grade 2 and wrist drop in grade 3, but both they require reconstruction surgery. So finally, in 1998, the current standard came, which is grade 0 with no anesthesia or no deformity. Then grade 1 is anesthesia present and visible deformity is grade 2. For eye no problem initially was grade 0, and eye problem with vision more than 6 by 60 was grade 1. Now in recently, grade 2 is any involvement of the eye, lag of thalamus, iridocyclitis, corneal opacities. Then indicator of delayed diagnosis is presentation of this visible deformity in a patient at the time of diagnosis. Now the EHF score is being used, which means eye, hands, and feet. So 2 eyes, 2 hands, 2 feet, grade 0, 1, 2 of disability. And this must be recorded at diagnosis and release from treatment. Maximum score is 12. Now moving on to types of deformities. So either the deformity can be specific, which is due to M. leprae infiltration, or it can be due to nerve, motor loss, or anesthesia, or there can be miscellaneous deformities. So initially on face there can be nodulation, loss of facial hair, nasal defects. So these nasal defects, it is defined as the rhinomaxillary syndrome or the facies leprosa, where the structures affected are anterior nasal spine, alveolar process of maxilla, nasal surface of palatine process of maxilla. So when these are affected, it leads to saddle nose. So saddle nose can either be due to cartilaginous part affected, which is affected earlier, and then bony part of the septum is affected later. So this depressed nose. Then concave middle third of the face. Why? Because the maxilla is also affected. Reduced maxillary projection is there. And then inverted upper lip. So this is the characteristic. We can remember it as that leprosy scribbles the face, so saddle nose, concave middle face, reduced maxillary projection, and then inverted upper lip. Then in the eyes, there can be loss of eyebrows, scleritis, iridocyclitis. So these are the specific M. leprae infiltration. And after that, due to motor paralysis in face, we can see facial palsy or leprous stare because of infrequent blinking. Then after facial palsy, lag of thalamus, which means that the eyes won't close. And due to anesthesia there can be anosmia, and if the eyes are left open there can be corneal abrasions or blurring. Miscellaneous is loss of taste and complicated cataracts that develop in the eyes. Now for the hands, the specific deformities, this can be remembered as uh, BFTS, so banana finger, that becomes frozen and twisted, and then soft silky or swan neck deformity. Why does this happen is because there is heavy infiltration of the skin, and then followed by a trophy, so there is banana finger. In case of frozen or reaction hand, due to multiple times reaction occurs, so there is frozen hand in which the hand takes form of a claw. Soft silky hand is also similar due to infiltration and the hands can become twisted. Reverse of this deformity is swan neck deformity. Here, uh, there is contracture of the intrinsic muscle. Here, there was infiltration up to the subcutaneous tissue. Now, the muscles get involved, so there is contracture. So, there is this flexion and flexion occurs at this interphalangeal joint. Then, in case of motor paralytic deformities, these are known as intrinsic minus, which means that the muscle have lost their function. So, due to ulnar nerve function affected, claw hand occurs. Wrist drop due to radial nerve, and Z thumb due to affecting the muscles of the thumb. Ape thumb develops, and then there is weak pinch also. Then, in the last, due to anesthetic deformity, there can be SMWT, which means that the shortening, mutilation, disorganization of the wrist, and formation of trophic ulcer. In the feet, there can be frozen foot, twisted toes, and due to motor involvement, there can be clawing of the toes. Due to sensory loss, there can be plantar ulcers or disorganization of the foot. Other deformity include sagging of the lobules of the ear, hoarseness of the voice, palatal perforation, testicular atrophy. Then a chronic simple ulcer due to loss of sensation. So it requires this POP cast and it can be attached to this bowler iron splint so that the patient is able to walk. So if for a foot drop is less than 6 months, then it can be managed conservatively by using steroids and then giving the patient foot drop, splint or this orthosis. Now, clawing of hand. So, this was the motor paralysis leading to deformity of the hand. So, ulnar nerve palsy, there will be intrinsic muscle will be lost. So, the deformities will be known as intrinsic minus. This is the Wattenberg sign, and then this is the partial clawing. This is the full clawing, which means that the all the fingers as well as thumb is involved. Total claw hand. So, before doing reconstruction surgery, there is Bouvier's test, where we hold the MCP joint so that the patient is able to extend this PIP. If PIP extension is not there, it means that we have to do exercises and that we cannot perform RCS right now. Then splints. So initially for the clawing, when palsy just begins, that there is just the Wattenberg sign. So we need to adduct the fingers. So we use adductor band. Then if there is mobile clawing sets in, then this is the best time to do the reconstruction surgery and we give splints to the patient pre-op as well as post-op. So what are the splints? They are finger loop splint dynamic splints. So this, how do we remember? For clawing there is FGATD. So for that is finger loop gutter splint, adductor band. T thumb spica for the thumb. D dynamic cocker splint for wrist drop. So finger loop splint. So wristband is there, four finger loops are there. So this will keep MCP in flexion and PIP in extension. Dynamic splint for the same action and knuckle bender splint. For if thumb is also paralyzed, we have to add this opponent's loop splint or there can be use of thumb spica. Then the exercises. So this is the active exercise where the patient will extend his PIP on himself while we stabilize the wrist with the opposite hand. This is the passive exercise where we extend by using the other hand. And we have to keep the fingers in motion. And this is the passive exercise for the thumb. And this is active where the tip of the thumb will extend itself. This is the thumb spica. And so in well, if there is mild stiffness in day use, we use loop splint. Gutter splint is for night use. Also, it will relieve the contracture if serially we use different gutter splints or we use POP cast. These are the gutter splints. So initially there was contracture. This is the use. It would be released. Serial splinting can be used for thumb IP. Gutter splint is also used for wrist drop. We use this static volar wrist cock up splint, and for dynamic this can be used. So wrist hand orthosis can be used here. For foot drop, this is the exercise where we can take cloth wrapped around the forefoot to pull it. We have to basically prevent the contracture of tendoachilles. So there is a below slab can be applied below the knee. And for lag of thalamus, this is the exercise that we do to do stretch laterally and upwards. So this is how we keep the patients in splints. And we can also use grip aids for independence in daily activity if a patient has deformity. So if the fingers are being used, so epoxy resin grip aids are there. Without finger, grip aid kit can also be used. Now for plantar ulcers, these form because of sensory loss, or in case of motor loss, which is the posterior tibial nerve, sagging at the MTP joint would lead to ulcer at this area. Clawing of the toes would lead to formation of ulcer at the tip of toes. And most commonly, forefoot ulcers are seen at the metatarsal heads, and less commonly they are seen in midfoot and the hindfoot. They are punched out, they have a dry base, and if serosanguinous discharge is there, they are the complicated ulcer. These require rest and mostly they heal. If they are deep, they require scraping, treatment of the infection, dressing, and surgical option we can remember as cysta, which is sesamoidectomy, uh, SS, subtotal metatarsectomy, transmetatarsal amputation, and A is addition of the flaps. Then very important is to wear MCR footwear. Then reconstructive surgeries, these can be remembered as that FDS, which is flexor digitorum superficialis. It fixes the fingers and thumb. Then fixing of the fingers, that is claw hand, and the ape thumb. And then we have to remember where what is the recipient also, which is written. Then for fixing of the extension, so PT, PL, and FDS, they fix the wrist drop. Amongst that, FDS will fix the fingers of, that is finger extension will be fixed by FDS. PT will deal with the carpals, PL with the thumb. Then TP fixes the toes, which means that the tibialis posterior will fix the foot drop, and temporal fixes tears, which means it will fix the lag of thalamus and restore function of the eyelid closure. So for claw hand, we know that the FDS will fix the fingers. So FDS, this is the FDS which causes the claw action, and this is the FDP. Now, how to remember the surgeries, that is lasso, indirect lasso, Brand's ECRL transfer, and Fowler's operation, that lazy Indians bring food. How do we do the surgery is that this lasso operation is that the FDS tendon, it is split into four, and then it is looped around the A1 pulley, and then it is inserted on the A1 pulley, which is this, or the extensor expansion of the flexor digitorum profundus muscle. So it would lead to MCP flexion and allow IP extension. Then for the ape thumb reconstruction surgery, normally this is our thumb, which is held by these gyropes, intrinsic muscles. If these are affected, the four muscles, then thumb will turn into ape thumb. So we will not be able to do the fine work. So how we do FDS of the ring finger? So FDS fixes the fingers and thumb. So it will fix this ape thumb. So it is first of all, it is split at the insertion. Then we will take the FDS out, and then we will retrack it on the ulnar side of the wrist, and then it is passed under this pisohamate ligament, and it is divided into two slips. One will go around and serve the function of abductor pollicis brevis, and the other of the extensor pollicis longus. So these two slips, they will allow the opposition of the thumb. Then for wrist drop, we have discussed the three muscles and what they work. And in foot drop, we will see that this tibialis posterior, it is taken out and then it is rerouted. It can be rerouted via subcutaneous route or via the transversus route, and then it is inserted at tibialis anterior or for the dorsiflexion. Then for lag of thalamus, the surgeries there can be tarsorrhaphy, which means that we can close this eyes, or tendon transfer or pedicle muscle transfer. So temporalis is taken. Temporis, it can be used in retrograde or antegrade manner. So this temporalis, this can be used for the eyes or also for the angle of the mouth. And other problems requiring reconstruction surgery are the, if nose is depressed, nasolabial flap or bone graft. Bone graft is the cantilevers. If brows are lost, so superficial temporal artery flap and hair graft from the posterior posterior to the ear from the occipital hairs. If uh, problem is that there is ulcer on the foot, so SSTA, we have already discussed the surgery that can be done. And if webs are sunken, so lipofilling can be done. And RCS, they cannot restore sensation, only motor function can be restored.